All right. Welcome, everyone. We have had so much fun this week having various conversations about life in motion with migraine. And for those of you who haven't caught our themes this week or what's going on this month, this is Migraine Headache Awareness Month. So for the entire month of June, we did start a little early in case you saw some in May because we wanted to circle back to those who have the comorbidities with mental health. And so this whole entire month, we really want to focus on the theme of I am visible. And we know that so many people tell us that they know they're visible, but this invisible disease that people don't necessarily see how bad it is carries into all walks of their life. So joining me today is Dr. Claire Sandoe. And Dr. Sandoe, welcome and thank you so much for joining me today.
I am looking forward to it. I have enjoyed your conversations with the other great experts you've talked to already.
Well, thank you. Thank you. And I'm excited to have a conversation with you about menstrual migraine. And you have become quite an expert in this. We've spoken with you a couple of times in webinar formats and other capacities, but I think this is so great for people who may be watching and trying to understand the correlation. So start by telling people tell people where you work, tell a little bit about your background.
Yes, who am I? So
Who you
I
are.
am Dr. Claire Sandoe. I'm a headache neurologist in Toronto at the University of Toronto, where I work at the Women's College Hospital Center for Headache. And I'm also co-chair of the AMF editorial board. So some of you who watched some of our previous webinars may have seen me moderate our women's health series, which touched on some of the topics like today earlier this year.
Yeah, thank you. And you've done such a great job and you're such a fantastic addition to the editorial board. And so often people don't know what goes on behind the scenes. So thank you. Thank you for all the hard work you do for our patients and making sure we get out really sound information to the patients. But let's jump into talk about the connection between migraine and hormone changes in women.
Absolutely. So this is a huge area, and as many people likely know, migraine does impact overall more women than men. Actually, before puberty, it's more common in boys, and then post-menarche, girls start to express more migraine than boys, and that stays true through the rest of the lifespan. And there's often a relationship with migraine attacks and hormone changes being impactful, whether that's menarche, when first periods start, hormone changes like being pregnant, breastfeeding, going through menopause. And so one of the biggest impactful hormones here we tend to think is estrogen. And obviously, there are general lifespan estrogen changes. Again, menarche, menopause, estrogen changes a lot. And then for women who menstruate, there's quite a lot of change from month to month. There's a dip in estrogen around ovulation and again just before the menstrual period starts that can be really impactful for migraine attacks. And we think it's in particular that estrogen change that's the biggest driver of some of the impact on migraine for women.
Yeah, yeah, that I know we could have like a several hours discussion on this, and it's so interesting because in the time I've been with American Migraine Foundation, I have met a lot of women who have said, or just people in the community were around me, and they said, "Oh yes, I started having migraine when I went through menopause. I had one migraine or one migraine attack, and then I was diagnosed with migraine after I had my first child." Can people have a headache or migraine episode only during their menstrual cycle and it still be considered migraine?
Yes, and that also just made me think of something else that I see a lot, which is people who come in and say, "Oh, isn't it normal to have a headache around my periods?" And it's relatively common for women to have lived with this and not realize that it was migraine. There is such a difference in the way that migraine attacks look from person to person. There can be severely debilitating ones, there can be mild ones, and sometimes people assume that if you're not in bed vomiting with the light off, it can't be migraine. And so a lot of women, I think, have normalized, "Oh, yes, I have a headache around my periods. That's just what it is." And to your point about people starting to live with migraine around pregnancy or menopause, that is absolutely often true, as there are those big hormone shifts in particular. And sometimes that's just a time when things get worse. And so, for anybody who lives with migraine, we think that any type of change, internal, external, can impact migraine, whether that's sleep or hormones or weather, things that you can't control. And so sometimes those things just build up over a woman's life and lead to the point where migraine is expressed in a way that it didn't used to be.
Wow, wow. As you're saying this, I'm actually have taken notes in every talk because I am learning so much and also just triggers thoughts for me. But it is so interesting because I would say probably 90% of my own friends would say, "Oh, I thought that was just a symptom." So I think even that one little takeaway is so powerful. So how does someone know if it's migraine versus just a PMS symptom or a menstrual cycle period, a symptom of what's happening hormonally? How do they know and go, oh, it's migraine? I haven't been treating it like that.
Really good question. So we have some criteria that we use as a standard worldwide for diagnosing migraine that look at the headache characteristics. And so there are obviously a lot of non-headache pieces that are really important to people who live with migraine, the brain fog and all vertigo, other symptoms that people may experience, but we diagnose migraine in particular based on what the headache attacks are like. And so commonly these are these headaches that are often on one side of your head, but they don't have to be. Often they're throbbing, they don't have to be. They tend to be moderate to severe, so they're bothersome enough that people might want to do something about them. And then often they get worse if people are trying to carry on with their day. So you might want to slow down or rest during these. And people often have sensitivities to the environment, like lights or sounds. Actually, lights and sounds are bothersome, or they may feel sick to their stomach or throw up. And again, sometimes people have normalized, oh, of course, I want to turn down the light. No, I wouldn't want to go to a concert. The children yelling is tough. And those to us are indicators that this migraine process can be going on. And actually, that people do have migraine. And of course, there are many other things that women can experience around their periods, like you mentioned, PMS, that can confuse the picture. But if people have these headaches that are slowing them down enough that they would want to do something about it, find it bothersome. Even like I said, if they're not in bed at the dark, this can be in keeping with migraine.
Yeah, that's a great point. Should people talk to their OBGYN or when do they need to say, oh, I need to see a neurologist? What's that process look like?
So I think most women who live with migraine can be well managed by their family doctors, their primary care providers. And I don't know that everybody has access to an OBGYN, which isn't necessarily needed. And many primary care providers are very comfortable with diagnosing and managing migraine. I think when things are not going well, if you're not getting the treatment results you want, if there's something odd going on, or if there's something unusual, like you need help with support planning pregnancy, or you have other medical conditions that might not be as easy for that primary care provider to manage, then absolutely getting a specialist on your team makes good sense.
Okay. Okay. Yeah, I was thinking whether, and that's so good for people to know if they don't have an OBGYN and it seems like it's menstrual related or PMS related, that they can still talk to their primary care doctor. It sounds like if they're able to get good care and they feel heard and they feel like they're helping them manage their care. So really, really great point. What are some of the first line treatments you would recommend for acute menstrual migraine?
Really good question. So the first answer is anything you might use for migraine, you could try for these attacks as well. But the thing also to keep in mind is that because of, we think some of those estrogen changes, for example, estrogen has dropped just before the period, some of the things that we normally do may not work as well during those menstrual attacks. And those attacks are often much more severe than the attacks at other times of month. And it's also worth keeping in mind that those attacks can drive frequency all the time. It puts your brain on the migraine path and it keeps it there for often days in a row. And just to the formal definition of menstrual migraine, per a criteria that headache neurologists love, is that you have attacks that start on 2 days before your period to the third day of bleeding, reasonably consistently. Doesn't have to be 100%, but 2/3 of the time. And so there can be a range from person to person. And actually, in a given woman, there can be a range from month to month a little bit in terms of does that start the day before the bleeding? Does that start the day of, for example? Um, at any rate, getting back to your actual question, so because estrogen has dropped around that time, many of our treatments may not work as well and the attack may be more severe. And so it's worth trying migraine targeted treatments, whatever your typical ones would be. But if those are not working, there are a couple of medications that are specifically studied for these attacks. There's a combination pill that has a triptan anti-inflammatory. That's a sumatriptan naproxen pill. And then there's ubrogepant, one of the gepants that have a few studies here. And then sometimes we look at whether there's something we should do just because of how truly disabling these attacks can be to keep them from being like that in the first place, like a mini prevention. So trying to keep the train on the tracks and not go totally off the rails, because as many people experience, if you're not able to treat early, things often go downhill and treatments may not work. And so for somebody who does have a very predictable time when that attack starts relative to their period, in a regular period, sometimes we'll suggest proactively taking something the day before you think the headache will start, up to a couple times a day for a few days in a row. And sometimes we use things like longer acting anti-inflammatories or triptans. We might consider using something like the G-PANTs. And it's always worth taking a look back and saying, what else is it that's going on that I could do to optimize those other changes that might be going on, like sleep, eating, hydration, things that might increase the risk of those migraine attacks being more pronounced.
Yeah, no, that's what great information that is. And so it sounds like one of the things that we've talked consistently about with different talks this week is keeping a diary. Sounds like that would be really important. How many cycles would you have to really track before you go to your doctor and say, "Huh, look at this. My headache does begin this date, or these are other migraine symptoms I'm having." What do you recommend if someone's considering keeping a log to see what's really happening?
Yeah, the diary is important and is necessary for confirming this diagnosis. Sometimes women think that there isn't a relationship, and there is, or sometimes the other can happen, and there isn't as much of a consistent relationship, but the diary can be really helpful. And as for our definition, you need 3 months of this.
Okay.
We don't really want people to be suffering for 3 months and not seeking help necessarily, but that can help guide some of those choices that I suggested around that mini prevention kind of option.
Okay, that's great. And what about manipulating your cycle to try to not have migraine attacks? Is that something that you recommend?
So this is a really common question that patients come asking, because these are the really disabling attacks for many people and they want to do whatever they can. And it sounds logical that if we think this is a hormone problem, we should fix it by fixing a hormone. Um, but at the end of the day, the hormones themselves are not as well studied for treating migraine as our migraine treatments are. And so we commonly try the migraine targeted treatments first. Most of the hormone strategies have their own risks as well, and some of them may be more or less safe for a given woman. That being said, there are some things that might be considered. So if it's overall safe, sometimes strategies to minimize periods and minimize the number of times that you have those fluctuations could be worth considering. So that might be something like an estrogen containing pill on a continuous basis, or not having as many times of the withdrawal bleed, or for example, a progesterone IUD that many women don't have periods on. There can still be some hormone fluctuations there, but they might get smoothed out. These don't help everybody, and sometimes people can be worse. It's always a bit hard to know before you try them. And again, we often start with the migraine strategies first. The other thing that people sometimes ask about is supplementing estrogen. And there are a couple of studies about using an estrogen patch to add it back in the time that it's low. But unfortunately, when you take the patch off, estrogen drops again, and that attack probably comes anyway. So that one may not be quite as helpful. The other thing that has a little bit of study here is taking magnesium between when you ovulate and when you start to have your period to try to reduce that attack.
Wow, that's great information. I was actually looking and I didn't share with everybody. I'm running the tech support too, so forgive me if I'm looking back and forth in case we have questions coming in as well. And we have quite a few people watching right now. I think this is such an interesting topic. I know we did a series, a webinar series for 3 months with American Migraine Foundation. And so as people are watching this, if you're like, oh, I have more questions, I have more, there's actually a great, the three-part series is on our YouTube channel. We'll make sure to put that in the chat as well. It's fantastic and it dives deeper into this topic and others. With women and hormones, and we kind of dive into everything over those 3 months, or a high level of a lot of different things, I should say. Um, Dr. Sandoe, you obviously follow research and therapies and things that are coming out. And is there something you're really excited about that you can share that's emerging that people can be excited about?
Some of our newer medications are going to be increasingly studied here. I'm hopeful that we'll have more really good studies on, for example, the G-PANT family of medications. And those I think are especially promising because we don't think that they give the medication overuse concern that some of our other options do. Some of those mini prevention strategies I mentioned, for example, taking a triptan twice a day for 5 to 7 days, those days count towards your triptan intake for the month. And for some women, that gets them dangerously close to not having more days to use without running the risk of medication overuse on a given month. And so something like those G-pants might be really potentially helpful to avoid running that risk. And then I mean, I have to say this field is always changing. It's changed dramatically even since I started my fellowship, which was in 2018. We've had so many new options, medications, devices, lifestyle strategies, cognitive behavioral therapy, yoga, all of these things that we're starting to learn more about their impact on migraine. And I'm sure that we're going to be finding more specifically here as well.
Yeah. Wow. That's fantastic. And I always like to close these sessions with a bit of hope. If there's a female watching who is saying, wow, I've had terrible menstrual cycles for 15 years, 10 years. It sounds like you've offered hope going, oh, you may not realize this is migraine. Is there any hope just for those watching and just managing this part of their life?
Yeah, so I think it's also maybe helpful sometimes to remember just how many women live with migraine. It's up to 1 in 4. So it's many other women who have this experience, although obviously it's different in severity and in the way that it presents person to person. So there's a huge community of support with EMF as well. But in general, of women who have this experience and who I think are starting to be heard more in terms of this is a real thing that women really experience. It's not just normal, it's not just a headache. And there is a lot of focus on things like education for healthcare providers and then new research to try to ensure that A, it's understood and recognized so that women can access care, and B, that there are those newer treatments that will be more helpful.
Yeah, absolutely. Well, thank you so much. I know that this went so fast and we could ask a lot more questions. I do encourage people to watch the webinar series we talked about. If you have any problems finding that, always let us know. We'll also throw it in the chat. And just to remind people, we'll continue this series through this week. And then through the month of June, we'll have different themes every week. So if you're not getting our emails and you don't know about this entire series, please make sure you sign up on our website at the very bottom of the page, because there, when you are on our e-blast, you can find out all the webinars we're doing, the different series, the different topics. We're doing those pretty regularly now, almost once a month is a pretty good cadence we're finding. So we invite you to join those. So thank you so much, Dr. Sandoe. Thank you for all that you do to support our community. Thank you to those who are watching. And we're going to just continue to put some resources in the chat as well, for those who are putting in questions. So thank you, Dr. Sandoe, and thank you to everyone who's watching.
Thank you for having
All
me.
right. Thank you. Take care.